All righty. I'm not sure how to turn this screen off. Okay. Just a second. Okay, going nuts with these calls from political campaigns, trying to poll. It's driving me nuts. Okay, I'm going to do a real short video and post it up anyway, even though no one's here, just to kind of go over a little bit of what's on this PowerPoint because it's pretty long. I want to make sure that y'all have looked at it. We'll just go over probably the first few here. These are referring to a chapter that's from a different book by Chahody and is not, Shinodi and Teeter. It's not the same text. This is the text that we're using that's cited on your syllabus. Meanwhile, this book is from, I had it written down somewhere. I can't remember. I've only used it one time, so, okay. We won't worry about that for now. First of all, what this is guiding you through, this PowerPoint, is all about how to actually engage with, assess, and intervene with persons who are 65 and older, from the young old, middle old, and old, okay? When you're doing a biopsychosocial assessment, it's not the same thing as a geriatric evaluation. And we'll talk about that a little bit as we go through the first few slides here, okay? A geriatric evaluation has to include a diagnostic workup, okay? So technically we could say that a biopsychosocial assessment has to have some aspect of a medical component about your physiology, not just your psychology, which we are mostly interested in social work and all counseling related fields, right? Psychology, marriage and family therapy, professional counseling, etc. So the diagnostic workup involves generally a team with the geriatric evaluation, and they list those for you: a doctor, a nurse, not just a respiratory therapist, but also other therapists like occupational, speech, etc., and a licensed clinical social worker. Now, I say a licensed clinical social worker instead of an LPC. An LPC or an LMFT may certainly be involved in assessing for reimbursement in facilities that are long-term care, such as nursing homes, or temporary facilities like skilled nursing facilities, or what we used to call step-down units. The reason we don't have those included here in this first slide is because, as I've mentioned before in this class, Medicare reimbursement for psychosocial examinations are only done for psychiatrists and licensed clinical social workers under Medicare provisions. Now, if insurance pays for that instead, certainly a private facility could have on staff a licensed marriage and family therapist or a licensed professional counselor who could do part of the geriatric evaluation with the rest of the medical team. So just know that distinguishing aspect and associate MFTs, LPCs with specifically private, nonprofit or private for-profit agencies. Medicaid is a different bailiwick. Medicaid is medical care for those who are low income or poverty level, or who are disabled and qualify also based on income guidelines. Medicare is specifically for those who are 65 and older, okay? So it's medical coverage for persons who are elderly, 65 plus, until end of life. So a biopsychosocial assessment can be part of a geriatric evaluation, but you're looking at things that are specific to elders and their developmental process on every aspect, every domain of life, from physical on the micro level to environmental on the macro level. So bear that in mind. So what information, it says here, is included in a biopsychosocial assessment? It's your demographic information, your you put it in the elders' words, what they describe as their typical day. And then you also want to get information about how they're feeling, what their sensory limitations may be. And this is where eyes, ears specifically are important, of those senses, but also the others as well. So you have vision, olfactory, your nose, taste, your, vision, eyes, ears, nose, and touch. So all of those can be involved, but the most common, especially with the young old and the middle old, is eyes and ears. So vision and hearing. That's why you see so many commercials that focus on those two. You don't see many that talk about how to find clothing that's specific to touch stimulation that may be unpleasant for certain elders, or certain detergents specific for elders. I predict we will be getting to that probably in the next 10 to 20 years for sure, because people my age, for example, in their 60s will be in their 80s, and those will be very relevant issues. Here's what I mean. If you think about infants, the earliest stages of child development, you see lots of commercials about detergents that are specific for infant skin. Well, we don't have that for elders, the last stage of human development. But I predict that we will, given time, because that will also be included in the 5 senses that are involved with elder care, because you'll have more of us that have those issues. So just bear in mind, it's all 5 senses. And also their own rating of their overall health. Now, it's important when you keep in mind doing biopsychosocial assessments, you're doing written documents. Remember that in social work practice, in any counseling practice, indeed, the written document is the most solid, concrete proof that you have that your observations are made in the first place, that they're relevant in the second place, that they're ethical. Well, we should switch that around. It should be that you've actually done the work, so you have documentation to support it. They should be ethical as reflected in the documentation, and by virtue of signed consent forms by the person that you're working with or their caregiver if they are not capable of responding to you and you have to count on a secondary informant. Secondary informant would be a caregiver or a family member, a designated person that the elder person has made prior to becoming unable to respond. So you have to, your documentation is what proves the essence of your work. It shows that you did the work, that it's ethical work, that it's respectful, and that you write things only that if the person you're documenting, and this goes for any age range, that any person you're documenting about in any form where you do any type of narrative or short statements or descriptions of their overall well-being, psychological well-being, their environment, their family, their social situations, any of that must be written in such a way that should that person themselves read that they will not be upset or offended. And that's number one. Number two, that should they read that, they are not surprised that whatever is there are things that you have told them and told them you would document. Okay. That's called empowerment practice, by the way, because if you write things that are not things that the person you're working with doesn't know about, then not only is that unethical and disrespectful, but it can be used very negatively for a negative outcome for that person. Of course, I'm thinking most of child welfare, but let me stay away from that and just talk about elders. Let's talk about elder abuse then. So if you write something about a case that characterizes the elder victim as difficult to care for, and you didn't discuss that with them and let them know that that was going to be part of the documentation, when they go to court, say they're not senile or dysfunctional in any way, they're totally capable of caring for themselves, but they've had someone trying to take advantage of them. So you go to court because it gets reported for abuse, et cetera, whatever. And you write something like that. The elder doesn't know it, who's going to court because of alleged abuse against them. Then alleged abuse that the elder has experienced on whom you have documented, then you, if not making that aware to the elder that you're working with, that that's in the record, when they go to court, that can count against them. And then the elder may end up still having to be victimized by this person that they've alleged abused them. So know that, okay? Let's see, let's back up one. So we've covered 1, 2, 3, 4 of a biopsychosocial examination. Their ability for active daily living, ADLs. That's an important abbreviation. And there are variations of that, the most important of which is instrumental activities for daily living. So daily living activities relate specifically to self-care for your caring for your physical body. So that's why bathing, dressing yourself, feeding yourself are the best examples. Instrumental are things that you do that require cognitive abilities. You can have good ADLs, but poor IADLs, okay? So instrumental ADLs then are those that are about your personal life functioning, your cognitive abilities, the way, if you can still write checks, if you're still writing checks, or you can still pull up your accounts online, that'll be something you'll be looking for. For me, when I'm in my 80s perhaps, or any of my age range, any of the 60-somethings in their 80s will be more about electronic functioning, because there'll be even more of that and more time for us to have a little bit of mastery by the time we're 80s that you should expect we should still be able to do. So anything that requires activities that involve our thinking, that's our cognition, then those are your instrumental activities of daily living. And then your general ADLs, there's the activities for daily living, and then the general activities for daily living that affect your cognitive abilities. Well, like your checkbook, I kind of got off that one for number 5. Let's just read it. Elders' description of their ability to satisfactorily engage in activities of daily living, ADLs, such as self-care, which I just talked about, and instrumental ADLs or IADLs that involve something about their personal life that they must think about doing. If they can't concentrate on money, such as cognitive ability for a general ADL affecting their personal life and money management, then that's an IADL. Hopefully that clarifies. 6, their psychological and emotional functioning includes their personality, intelligence, memory, possible delusions, delirium, or dementia, their mood, anxieties, and potential suicidal ideation. And by the way, suicidal ideation can manifest with impaired IADLs. So someone may be at a state of dementia such that all they can barely do anymore when you're seeing them is do their personal care. They can't think about stuff, but somewhere deep down, they have these ideas to just do harm to themselves, and they do it without things. Kind of like how people will cut to hurt to release endorphins. All they're thinking about is something they can do to end their lives, maybe, but they're not thinking about why or anything other than their sensory input of, oh, I got to stop this, maybe. So suicidal ideation could actually go along with dementia, but you would see that very obviously with someone, inflicting self-harm or if not able to speak about it, acting in ways that are very detrimental to their survival. Number 7 is description of his or her personal lifestyle, what kinds of things they need for their social supports, what kinds of accommodating things they need for functioning well in their environment, whether it's in their own home or in an assisted living facility, which is different than a nursing facility or a rehabilitation facility for elders. Typically, you can have an elder who is completely intact, completely functional, able to care for themselves in a nursing home temporarily for rehabilitation purposes. And in my opinion, having seen the evolution of step-down units, which I referred to earlier by that term, or rehabilitation facilities, has become blurred somewhat with nursing homes. And I wonder, in my personal opinion, if this is because of the stigmatization that's gone with the term nursing home. Because we think of that as persons who are elderly and unable to care for themselves, or who don't have caregivers to provide for them, and are not able to navigate their environment safely, even if they are cognitively intact. And that's not necessarily true. Now we have rehabilitation facilities / nursing homes that are doing both activities, having people who are in a facility to provide ongoing 24/7 non-critical care in a way that allows that person to continue rehabilitation that would not be appropriate for a hospital, and to provide them the rehabilitation time such that they're able to return to their previous level of functioning, which may actually be in their own homes again. Okay, so bear this in mind, that when we talk about rehabilitation not being able to continue reasonably in a hospital, that means that a person has rehabbed enough from a critical incident, whether it's like a stroke and needing to rehab about eating, or using an impaired muscle arm or leg or side of their body, whatever, that they get to a certain point where it's going to require weeks and weeks and weeks in order to master that full rehabilitation to function independently. Okay, so they may be transferred from a hospital into a long-term care, or that's another term used for nursing home / rehab. So long-term care / nursing home / rehabilitation kind of all have been used, in my opinion, synonymously, though there are scholars and professionals in geriatrics who would, I'm quite sure, debate that. So just know that that's, in my opinion, that's an evolution that's happened because of stigmatization of nursing homes, and also, in my opinion, because of further corporatization of long-term care, rehabilitation, and nursing home functions. Okay, so you need to find out what kinds of things they need, and that involves talking about their family and identifying them as contacts with that elder's permission if they are cognitively intact and functional, prior to your working with them in whatever capacity, whether in hospital at discharge time or whether in a long-term care facility, such as a nursing home or rehabilitation. And don't forget their sexual functioning, even if they're not married or if they're widowed, because though elders may find that embarrassing to talk about, because that's a perennial, meaning it occurs across all generations, over all times, embarrassment about talking about sex. So, we're supposedly this liberal society, yet when it comes down to the personal one-on-one micro level, we are very inhibited sexually. So we don't talk openly about our sexual needs and sexual functioning. And so, for example, an elder would probably find it very weird and embarrassing, say from my generation, the baby boomers, who you'll most likely work with. Most of those will be baby boomers. Because we have the end of life for many of the greatest generation that came before us, right? So even baby boomers will still have difficulty, and I predict the millennials and the subsequent generations after will still have embarrassment, and so will you as a provider, to ask about sexual functioning. And we want to skip over it, right? But indeed, it's actually kind of a, personal need. So let's take two situations with sexual functioning. One, you've got a male. We talked about them last time on our recordings. They can maintain their libido a lot longer into even old age, longer than women can, right? So women don't need intercourse for sexual stimulation. By the time they hit old age, young old age and on, it's not about vaginal intercourse for stimulation. Although it is entirely normal for young and middle old to still be sexually active. And indeed, as we heard last time, I think it was Ms. Spears might have been talking about that there was a couple, I'm not sure what age range. Ms. Spears will have to clarify that for us, or we'll have to go back and listen to the video, which I will do, of course, because I want to remember how old that couple was. Were actually having sex, intercourse in their nursing home room. So it happens. It's not frequent, but it is still a need. And there are delicate ways that you can address that with someone. You can say, were you sexually active? Do you feel that you have ever had the occasional need for self-stimulation? You don't have to say masturbation, though that's what we're talking about with self-stimulation, right? But to ask that, are there needs that you may have that we can indicate to, say, nursing staff or caregiver staff, personal care attendants, PCAs, that needs to be known so that you have quiet time where you are respected, so that you can do whatever you want to do. And that includes if you want to engage in some self-stimulation. If you have paraphernalia that, if an elder has paraphernalia that they might use and wish to bring with them, there's no reason why they shouldn't if they're cognitively intact and aware. At the same time, if you had someone who is less cognitively intact, are increasingly losing the ability to self-care, you may have that stimulation similar to what I talked about with suicidal ideation. That's a very subliminal, we might even say id impulse that drives that human need, right? So say you have an elder gentleman, and I'm thinking about an elder gentleman back in the day when I did volunteer work at a nursing home for my undergraduate degree, that, this elderly man was, was very senile, and the staff had trouble with him, just whipping out his penis anywhere and everywhere pretty routinely, especially when he was out among staff. And that's when I happened to encounter him, in a wheelchair coming toward me with the PCA there. And he looks up at me and just whips it out and starts, going to town. So, it happens, and you have to be prepared for that. And the way to be prepared is to not skip this item on the biopsychosocial evaluation, because you can ask about that. And indeed, it's essential that you do if you have someone who you're doing an assessment on that is cognitively impaired and you're getting information from a caregiver. You want to ask them, is this an issue? Is self-stimulation an issue, or any kind of stimulation, and stimulation involving others, perhaps sexual activity, an issue with your father, mother, aunt, uncle, whoever, that you are a designated caregiver for? And if they tell you, you note that so that the faculty and staff are prepared for that. They know that ahead of time. You'd be surprised how often that is just not even mentioned that there is a propensity for a resident to do open self-stimulation because of their dementia. So don't skip it. It's important. And those are examples of how you can handle that with discretion and sensitively. And then also descriptions of spirituality, what their personal beliefs are, what pastors they have or priests they have, or what rituals do they generally and routinely participate in. Again, if they can't tell you, then the caregivers can. And that way you can be prepared for whatever their religious beliefs and practices are that the staff should be prepared for. That's also a factor involved in a cultural assessment, included in the biopsychosocial, which needs, well, I'm tripping over my own tongue today, which needs to be included as part of that. In fact, we might even say a biopsychosocial cultural functioning assessment, because we need to be sure we include that. And the elder's description or their caregiver's description of their financial status and financial resources, how they manage them, etc. And then their general living environment, whether they live in their own home, if they have accommodations for any limitations they may have, before or after your evaluation. Say, for example, you're doing the evaluation as part of discharge planning for that elder person home. Part of that would include what kinds of adaptive equipment does this person need? And that person can tell you. It actually may even be ordered by a physical therapist or an occupational therapist who may also be involved in home health care, as you may be as well if you were doing discharge planning from a hospital. Unfortunately, if we turn these around, instead of starting with number one, the demographic information and their basic descriptions of their own functioning and talking about all of their basic needs, which needs to be first. Unfortunately, our very first assessments are financial. We want to know what's your ability to pay. And that's whether in hospital and in a rehabilitation hospital or a rehabilitation / nursing home facility, a long-term care facility / nursing home / rehab, any of those that go together or are provided all in one setting. Those are what come first, whether it's nonprofit or for-profit. I want to know how you're going to pay for it. This is very important when we talk about Medicare and Medicaid. You have to understand, and elders often do not if they don't pre-plan. And I'm gonna tell you what, you're gonna encounter a lot of baby boomers, I keep telling you, because we're already in that geriatric population, that last stage of human development. We're at the beginning of it, right? In our 60s. So we have a lot of demographic information, collective information from the Census Bureau and different think tanks that have studied our generation, that we've not done a whole lot of savings. We've not had the capacity to really save well. So you're going to have a lot of people that their only ability to pay is through Medicare. And they may have a supplemental policy that they use in addition to Medicare. But if they are counting on having only a house as a resource that they paid for over their lifetime, that may be all they have. Or if they did a reverse mortgage, which all that means is that the bank is paying them month by month for their house. At the end of their time of living there, whatever's owed on that house, their descendants who inherited have to pay that. Okay, so they have to either sell that house, say a parent or parents have a house that's paid for and it's worth, maybe it's inflated to $400,000. but they spent 10 years in a reverse mortgage. Well, that 10 years may be at a higher rate than what they mortgaged it for to begin with. And so they're going to base it on that sale price. That means that that parent is not going to be able, let me start over. That means that those descendants who are inheriting that property will have to pay the difference between 10 years and 30 years on a $400,000 loan. You get it? So it's not a deal. I don't care what Tom Selleck says on those commercials that are targeted for elders. Oh, this is the greatest deal in the world. No, it's not. Not if our generation, and that's who those ads are targeted for, are interested in passing on anything at all for most of us, much less any property. So that's an important aspect of Medicare that you need to know, because Medicare does not pay for nursing home. It doesn't. Long-term care also has limitations on rehabilitation. So that's important to know. And that's why that comes first. Nursing homes want to know, who's paying for this? Are you paying for it privately? Or are you paying for it through a policy, a long-term care policy you have? And you will encounter more of those than you are encountering with the very old today, because those policies were not available for them. But they are available for us today. So you'll see more of that by the time you see our generation as the very old, in nursing homes especially. So just be aware, sadly, number 10 is always number 1, because that's the nature of our society. We are a democratic republic with a very strong monetary system that is driven by consumer participation, corporatization, and so therefore, that's why it comes first. It's very sad. We'll talk before this course is over a little more about Medicare. We also cover that in policy. Okay, so we're going to stop with just those basics of biopsychosocial assessment. And then I'm going to pick up with these, which are mini exams that you can do, depression scales, other assessments about how to do the biopsychosocial with certain tools that you can walk through as a just kind of quick checklist. And then you go over that checklist with that person and or their caregiver to make sure you have the best, most thorough, comprehensive biopsychosocial assessment you can do for the care and well-being of the elder. Okay, so we're going to stop there. We're going to start breaking this up in small Zooms for you so that you can process this stuff. Okay, now I'm going to put it on Blackboard for you. Well, it takes a few minutes because I have to send it to the iCloud and then I can upload it. But I'm going to set up your assignment now. Okay, so that's it for now.